Well, good afternoon. I've just been told the doors have been shut, so you're trapped in here with us for the next little while. But you are among good company. My name is Kevin Frankish. I am a communications specialist here at Ontario Shores Centre for Mental Health Sciences, and I welcome each and every one of you here joining us this afternoon. We would like to acknowledge the lands and people of the Mississaugas of Scugog Island First Nation, which is covered under the Williams Treaties. We are situated on the traditional territory of the Mississaugas, a branch of the Greater Anishinaabe, which includes Algonquin, Ojibwe, and Potawatomi. We are grateful for the opportunity to work and provide care on these lands, which are home to Indigenous peoples across Turtle Island. Ontario Shores is committed to cultivating meaningful relationships with First Nations, Inuit, and Métis peoples as we work together in support of mental health in our communities. And speaking, this is just a little factoid to throw out there, speaking of mental health in our communities, when we deal with our First Nations, the worry over the increase in dementia cases is exponentially worse in our First Nations. We're expecting a 187% increase in diagnosed cases of dementia for the general population, 187. But that's by 2050. And for our First Nations, it's a 273% increase that is expected. This is because of poverty, because of segregation, because of outstanding issues with truth and reconciliation. So it's something to keep in mind, definitely. We are talking about overcoming apathy this afternoon to build an engaged, dementia-friendly community. And it's this engaged community that is going to be the focus. I wanted to point out just a couple of interesting things in which we do engage an actual community at large. This is a diner in Japan, and it's called the Restaurant of Mistaken Orders. It is staffed by people diagnosed with dementia, and there are volunteers there helping them. The idea is to get the community at large familiar with those living with dementia, and that we don't hide our loved ones away. So they get out there, and yeah, they may get the orders wrong, but the customers are patient, and usually what happens is conversation. And they start to realize, well, maybe someone with dementia is not that scary after all. I wanted to bring another example of community involvement. This is from a video that I produced for Ontario Shores last year called The Caregivers. And Maria Villas in Montreal and her mother, who lives with Alzheimer's, she brings her out into the community. She puts money in her wallet to allow her to pay for lunch unknowingly. And she hands to people this card whenever she has to deal with a server or a cashier. And it's in French. Here's the interpretation. The person who is with me has dementia. Your smile and comprehension will add sun to our day. Again, it's that familiarity. It is making it a little bit more normal for an interaction within the community. So just a couple of things to keep in mind as we put the pieces together for this afternoon. I'd like to bring our power couple up right now. They're our hosts as well. Would you please welcome Dr. Winnie Sun, who is Associate Professor, Faculty of Health Sciences at Ontario Tech University, and Dr. Amr Burhan, a geriatric psychiatrist, endowed chair for applied mental health research here at Ontario Shores.
Thank you so much, Kevin. And thank you all for being here. It's our pleasure to welcome you. This is the third showcase event for our center. So I'm actually going to just go over a few slides. The one slide that's provided by Winnie is about really hearing from the Member of Parliament, Honorable Lorne Coe, about our center. It looks like this was at least an endorsement that what we're doing is meaningful for this region. So I'm going to just start this here. Oh, didn't start, but I'll I guess maybe, there we go. So we'll see if the magic that Kevin performs will. If not, we'll move on. Anyway, okay, well, I got the head shake. So anyway, the content of this is really acknowledging that this is, the attempt by Ontario Shores and Ontario Tech University to partner to create meaningful engagement with our really stakeholders and people living with dementia and their caregiver is something that at least seems to have caught the attention of our Member of Parliament. So the ADCC, or Advancement for Dementia Care Centre, is meant to really create a really advanced evidence-based, person-centered care for dementia. There's, of course, a lot of issues under that we are working through, the stigma prevention, and making sure that our care is culturally inclusive, and of course, protecting the safety of older adults. We also think about quality of life and recovery, despite that the illness, dementia, is challenging us in the sense that people are progressively losing life skills and cognitive function, but we do think that there's a meaning that's always going to be maintained and a person there that we want to care for and promote their recovery and empowerment is part of that. Really looking at technology-enabled care, we know that Ontario Tech University has a lot of technology to offer at all levels, from simulation to virtual care to virtual reality. And I think that this partnership will allow us to bring technology to care. And of course, this workforce, because we know that a lot of people get trained in the Faculty of Health Science, but we all have a lot of students and health practitioners that train with us. So really finding a way to empower and prepare the workforce is part of what we're hoping to do. So I think this is where Winnie going to share with you some of her work that we collaborate on.
Thank you, Dr. Burhan. And just wanted to go back a little bit to highlight the importance of this member statements from Mr. Lon Coyle about ADCC's vision statements at the Legislative Assembly of Ontario, really highlight the impact of the work that we're doing in Durham region and beyond. Okay, so thank you for Dr. Burhan to really describe a comprehensive picture of the ADCC research pillars. And this year, we are really grateful to receive funding from CRHR Planning and Dissemination Grants. And really, we wanted to further refine the research pillars that we already have. And the intent is that we wanted to engage in co-designing, participatory approach to co-creating this ADCC future vision in Durham region. And that what we do is we wanted to involve caregivers, people with dementia, and healthcare providers, really to ask this question: what should be the future research priorities of ADCC from the perspective of the people with dementia, caregivers, and researchers, and what are the perspectives and preferences of future engagement in dementia care research? And that is a really critical question. So what we're going to do is we will have this discussion, conversation cafe that we call, and that it would take place across Durham region partners. So what we have is currently we will engage the Ontario Tech faculties, also Ontario Shores, and also we have different partners who are already engaging in this project, which includes the Alzheimer's Society of Durham Region Long-Term Care Homes, Oshawa Senior Community Center, and also Senior Care Network. And the intent for this project is we wanted to create a knowledge dissemination summit, and we hope to have that take place in June 2025. we wanted to share some lessons learned and some key themes. So what have we learned from the participants, and trying to get to know what should be the research priorities, what are their needs and struggles, and how can we do better in order to address those needs and struggles. So this is, we're still ongoing recruiting participants about this Conversation Cafe. If you are interested, any organizations or individuals, please reach out and contact myself and Dr. Burhan. So there is also a various demo, technology demo that we will be showing today. So ADCC research pillar really heavily emphasized the technology-enabled dementia care innovations. So what we're going to show is one of the work that we are leading is the virtual reality reminiscence therapy, leading by myself, Dr. Cavito, and the Alzheimer's Society of Durham team. And also it was initially pilot tested in Ontario Shores in the geriatric dementia unit, and we plan to scale up to the Alzheimer's Society of Durham and region of long-term care home as well. So reminiscence therapy is a multi-sensory treatment that uses a combination of sight, sound, touch, smell, in order to help people with dementia to remember events, people, and places from the past. So this is just an example of what the demo would look like, and we're going to use MetaQuest 3 headsets, and that there are already tailored VR contents already uploaded to stimulate some of those cognitive engagement, promoting that reminiscence therapy to help families, to help people with dementia and families to remember those memories from the past. And there are family pictures, oldie songs, their favorite videos downloaded already in the system. So really to engage the participants to explore the VR world, and then they can travel to different places, different countries, or places that they really want to go, like hiking, swimming, and engaging in different activities, cognitive stimulation activities such as Zumba dance, or even cognitive stimulations extra game. So this is another addition of the virtual reality reminiscence therapy features that we added, and it's called the conversational AI. We wanted to see if there is a role of the use of AI to promote the use of reminiscence therapy. So there will be a chance for you guys to actually try out as well. Okay. And this is another example of a technology-enabled dementia care innovation that Dr. Burhan and I are working on as well. We wanted to showcase today because it is the flu season. So this is the perfect opportunity to really engage your learning about hand washing and infection control and vaccine education. So this is an infection control extra game that were developed by myself, Dr. Cavito, Dr. Burhan, and also Dr. Gamble and the team. So we wanted to educate people with dementia and caregivers about the use of extra gaming, to educate about hand washing, influenza vaccine, to really see if there's any physical, social, and educational components of the use of exogaming. And the other, aside from the innovations that we are focusing on, we're also focusing on building capacity. So building capacity is focusing on how do we promote a workplace retention for older adults, the care of older adults, and also looking after people with dementia. So this is a preliminary workforce retention framework that is created based on the support from VRPN and also from the Durham region. And this circle really summarize what are the key factors that would help support workplace retention so that we can better support the healthcare workers who are looking after people with dementia and older adults. So there are different factors and multifactorial approach. So we have to look into the individual factors, organizational factors, and systemic factors as well. So these are some of the workplace retention factors that we find in our research to build this framework. And that the individual factors really have to look into the personal life, the resilience, continuous learning, which we heavily focus on, and I will talk about how, what Ontario Tech University is focusing on the continuous learning to help support dementia care workers. Organizational factors looking into the policies, procedures, consistent communication, team culture to embrace diversity, and also the systemic factors, looking at the legislation, educational preparation, the resource allocation, and the external factors, looking into the media, community relation engagement, and the future prospects of healthcare workers. And you can see that there are multifactorial factors that are involved in the promotion of retention of healthcare workers to support the care of older adults and people with dementia. And this work, it's really getting attention from the ministry. I'm actually going to present these findings to the Ministry of Long-Term Care on Friday, which is a great thing that the ministry is actually really, really interested in promoting how do we better promote the workplace retention. And also, I talk about how it is important to promote the continuous learning, and that in Ontario Tech University, continuous learning, we actually developed a micro-credential dementia care program to support healthcare workers. And this micro-credential program was developed in collaboration with Ontario Shores, Alzheimer's Society of Durham, and Durham Long-Term Care Homes, and Baycrest, and also Neurofit, which is our industry partner. So this program really focusing on the 9 modules, and that encompassing all the essential, enhanced, and specialized competencies, and that focusing on the relational communication, stigma prevention, elder abuse prevention, understanding responsive behaviors, cognitive assessment tools, self-care for dementia care workers, and going up to more specialized learning, which involves palliative care, crisis intervention, and cognitive rehabilitation. So these are all the essential learning and competencies that really help support healthcare workers working with people with dementia to promote better care. So if you have any questions about this program, please go to Chris Doyle. He's sitting right in front, and he can answer any questions that you have about this program. And that this is just an example of the use of virtual simulation-based learning that's embedded within the dementia care micro-credentials to help support workers to develop that critical thinking and also clinical judgment. And the other way that we build capacity is build capacity in student research in dementia care. So we have done multiple projects that is co-supervised by myself and Dr. Burhan, and also committee members involved by Dr. Gamble and also Dr. Mary Chu. So there are student posters that are already put up in the lunchroom that if you have time, please go to the lunchroom and just take a look at some of the fantastic work that students are doing in dementia care research. And also there are student video presentations already posted on dementiaresearch.ca, our website. And there are multiple student presentations talking about some of the work that they are doing in the field of dementia care. And I wanted to finish off with this slide and then go into Dr. Burhan talking about his work focusing on caregiver intervention. So this work is really about how ADCC is really looking into an integrated dementia care model. And this model, we're planning to go moving forward. We believe that it is important to put the pieces together. And using the different types of innovations and practice that we already have created, and how does that look like to help prevent cognitive frailty and physical frailty. And this work is based on Canadian Frailty Network. And we wanted to see if a VOI frailty model can help reduce, can help promote healthy aging and dementia care. So, for example, A is activity. So we already have, innovations related to Tai Chi, Zumba, cognitive stimulation, exergaming, and sleep hygiene diary. And then we have V for vaccination, right? So you're gonna have a chance to try out the demo out there. It's the infection control exergaming. And then we also want to look into optimizing medications, how to use gamified, empower education about medication management for older adults and people with dementia. And then also interact, right? Interact to increase social engagement, social connectedness, using virtual reality reminiscence therapy and also robotic dog, to create that sense of social connection. And then diet, D, and nutrition, very important to really support older adults and people with dementia about sodium dietary intake. And we have already a web-based sodium dietary screening tool, and that was created by Dr. Joanne Akan. Will be collaborating with us, ADCC, to see if there's any benefits to the use of web-based sodium dietary screening tool to help older adults engaging in better diet and nutrition. So this is an example of our future vision moving forward, the use of integrated dementia care model. And this is the reason why we also bring together an amazing panel today. We want to look at the different factors, right? And putting the pieces together and looking at dementia care from multifactorial and comprehensive approach to tackling some of the issues and how we can do better with older adults and people with dementia to promote healthy aging and dementia care. Okay, thank you.
So I'm just checking on the time. It looks like we're about 10 minutes behind. That, of course, we want to give our keynote. Hopefully, we'll be able to compensate later. So I'm just going to spend really a couple of minutes. I mean, some of the studies that we're part of that's kind of more clinical focus. There's some work that we're doing part of the national network looking at people with mild cognitive impairment and looking at physical activity. This is part of a synergic trial. It's part of CCNA. The virtual reality caregiver intervention, you're going to see a demo in a bit in terms of what are the scenarios being developed to look at communication with people living with dementia who have apathy or difficulty resisting, not wanting to accept care and so on. And just to remind you that it has really a gender spin into it because we know 75% of caregivers are females. Through the Toronto Dementia Research Alliance, we have been partnering on several projects that I'll share with you. One was the standardization of the neuropsychiatric symptoms management that ended up being funded actually by, so after we did this study that's funded by Brain Canada, now the Slate Family Foundation have funded, provided really $30 million gift, but $6.5 million of it really looking at technology-enabled integrated care pathways. So this is something that you'll see coming, that had CAMH and Ontario Shore partnership. This is the work that you're going to hear from our guest speaker on cannabinoids. They have already published their first study, and now we have two studies that are part of our recruitment at Ontario Shore. We're one of the sites, one for Nabilon, which is synthetic cannabinoid, and one is the CBD preparation. So I was mentioning earlier to some of you that these studies are ready, and they're already recruiting and supporting people living with dementia. And we're also working on the wearable devices as a way to detect changes in people's behavior. So this is the preliminary work that showed that at least we can identify a signal of emotional distress earlier than the manifestation of that distress. So eventually, hopefully, this will translate to a dashboard for clinicians to know that agitation might be happening and therefore to do something before it become a bigger problem. Just to acknowledge, this is really a work from Ontario Shore, Ontario Tech, where we're partnering in this. You can see the team from Ontario Shores, including myself, Mary Chu, Tim Pauly, Kevin, of course, who have been amazing support, Amanda Nixon, and Angie Miller, who's a clinical nurse specialist in our unit. And of course, Ontario Tech with Winnie, Brenda, Jennifer Freeman, Julie Armstrong, Caitlin Gambier, Fiona MacArthur, and Alison Carruthers. So we have a website if you want to check on what we're doing, but for the sake of not delaying things further for our keynote speaker, I probably will just pause here and thank you for seeing our update. I don't think we have time for questions, but if there's any burning question, we could take it either now or after. Okay, so maybe I'll take the time to introduce our keynote, and I think we promised 35 minutes, so we'll honor that, Krista. So let me thank you, Winnie. I'm gonna just make sure that we stay on target here. So it's my immense pleasure to introduce Dr. Krista Langto, who's actually a clinical pharmacologist, have been in the Sunnybrook side. She graduated in '98, but has been with Sunnybrook as a now senior scientist at the Horowitz Brain Science Research Program, and the head actually of neuropsychopharmacology research unit that has been quite active over the years in producing amazing work. It's also the Bernick Chair of Geriatric Psychopharmacology. Now, she's a full professor in the University of Toronto Psychiatry Department, and she has been immensely productive over the years, definitely approaching 400 articles, peer review articles, and really the membership on the executive committee of the Department of Psychiatry is another testament of her role in supporting scientists in the department. So she is the vice chair for clinical and basic science at the Department of Psychiatry. So there's a lot to say about Dr. Langto, but I'll just give her the time to tell us about apathy.
Thank you so much for that introduction. Can everyone hear me? I know I'm short. I got to keep the microphone down. So it doesn't come up on this screen, right? I have to turn around to see the slides? Yeah? Okay, I'm going to stand like this. So I wanted to talk to you about something that's near and dear to my heart, and that's apathy, because it's actually one of the behavioral symptoms that's under-recognized. I do have disclosures. I'm a consultant, or I'm on the advisory board for a bunch of drug companies, but everything that I'm presenting today is from peer-reviewed research. So this is the research that we do, not the research that drug companies are doing. And I had three things that I thought I should speak with you today about. First is just apathy, its importance and its prevalence, because it's really under-recognized out of all of the behavioral symptoms. And then two new findings that we've been working on. First, the diagnostic criteria for apathy. You can't treat something until it's a thing. You have to have diagnostic criteria, just like you do for depression. You have diagnostic criteria for that, and then you know to treat it. We recently came up with the diagnostic criteria for apathy, and they were updated, and those are now accepted by drug regulatory agencies. And once you know it's important and it's a thing, then you want treatments for it. So just some of the research that we've done to try and find medication treatments for apathy and Alzheimer's disease. So I know we heard a little bit about dementia, and you probably know about it, but I just wanted to focus you in on it again. So the core diagnostic feature of dementia is cognitive impairment or cognitive deficits, problems with memory and learning. And then when you have that, what comes along with it, that's the C, is the A, the activities of daily living. So the more severe your cognitive impairment, the more you lose your activities of daily living. But we're going to focus on the B today, behaviors. I call them neuropsychiatric symptoms. They're a heterogeneous range of psychological reactions or psychiatric symptoms, and they result from the presence of dementia. So they're new in people once they have that diagnosis. It's been estimated that even though they're not part of the definition 90% of people will have one or more of these behavior changes whenever they have dementia. So this just shows you some data from a meta-analysis, so a big review of a bunch of studies that shows you that of all of the neuropsychiatric symptoms, all of the changes, apathy, though under-recognized, is actually the most common. Cross-sectionally, if you look at any point in time, about half of people will have these symptoms. So that's cross-sectionally, but if you look over time from the Cache County study, the 5-year prevalence, 71%, so almost 3/4 will have symptoms of apathy over 5 years. And the reason why we have this vagary in how many people have it is because the prevalence becomes more common with increasing disease progression. So you can see in the graph on your right-hand side that CDR 1, 2, and 3, that corresponds to mild, moderate, or severe dementia. As you move to more severe, CDR 3, over 60% of people at any point in time will have apathy. There's also been a meta-analysis of sex differences. They have the same prevalence, but you tend to have greater severity in males. So that's just the severity. What about the impact? Well, apathy has a big impact in inpatients and in outpatients. So starting with outpatients, if you have apathy, you have a greater risk and a greater rate of cognitive decline and a greater rate of functional decline. So this is one of the first studies that showed it by Starkstein et al. They looked at 354 consecutive outpatients with AD, so they didn't skip anyone, they took them all, and they managed to follow up 70% of them 4 years later. And they found if you had apathy at baseline, you had a faster cognitive decline on the mini mental status examination and a faster functional decline on the FIM, the functioning independence measure. It's also been correlated with caregiver burden, so it impacts the patient, but it impacts the caregiver. This was another large study, over 500 memory clinic outpatients, and they looked at predictors of ZBI, that's a Xeric Burden Inventory. That's a measure of caregiver distress and caregiver burden. And they found that, like you expect, the severity of cognitive impairment was associated with higher burden, your ability to function, independent activities of daily living, higher function if you weren't doing that, but also neuropsychiatric symptoms. Out of all the neuropsychiatric symptoms, including depression and agitation and aggression, it was actually apathy that had the biggest impact on caregiver burden. The more apathy, the more caregiver burden. And I'm going to show you some of the features of apathy so that you can understand why that might be. First, though, let's look at the impact in people in long-term care facilities. So you can see from this graph, that's the survival probability. And here, surviving is living or dying. So that's from people on the left-hand side in a somatic care unit, so just a regular care unit, and people in dementia special care units. So even in special care units dedicated to dementia people, you can see people without apathy are the black line, people with apathy are the dotted line. Apathy is associated with an increase in mortality. So that's a heavy-duty patient impact. If you have apathy, you're more likely to die, whether you're in a somatic care or a dementia special care unit. Every 1 point increase you have in your score, you have a 62% increase in your mortality rate. So it's important that we try and find causes of apathy and try to improve our treatment of apathy. So treatment of apathy, do the medications that people are already receiving for Alzheimer's disease, maybe they help with apathy. It would be nice if they did, but I'll show you that they don't help very much. So one of the best ways at looking globally at the literature is to do a meta-analysis. So you look at all of the studies. So my previous PhD student, Mayuri Rathira-Kuhan, did that for us, and this is the graph that shows the first group of medications, cholinesterase inhibitors. They're the ones that are most commonly given. She found 6 studies. Over 3,500 people were treated with this group of drugs, cholinesterase inhibitors. But all of the trials were targeting cognition. They weren't targeting apathy. Still, if you look at apathy as a secondary outcome, you can see from this that this group of drugs, cholinesterase inhibitors, slightly improve apathy compared to placebo. but the difference is less than 1 point on the scale. So it's a tiny difference. And you can see here that it's just barely squeaking over the line. It slightly favors cholinesterase inhibitors for the licensed ones now. And this is for the ones that were withdrawn from the market, unlicensed. So it's just barely statistically significant. So this was a Cochrane collaboration meta. The evidence is considered low quality, and because of this small effect size and that they didn't diagnose people with apathy first, it's just doing all takers, the clinical importance remains uncertain. So the major groups of drug used, small effect, not sure whether it's clinically important. The other ones that are used in moderate to severe Alzheimer's disease is memantine. So this is another meta-analysis published, 11 studies, 4,200 people. In this particular one, they looked at memantine versus placebo, as well as memantine and the cholinesterase inhibitors versus the cholinesterase inhibitors alone. So at the top of this forest plot, you can see that memantine alone showed no improvement in apathy. If you were to draw a diamond yourself freehand, I don't think you could get it more solidly on the line of 0 than memantine is there. And it's not 10 patients, it's 4,261 patients. So we don't have high hopes that memantine is going to help your apathy. It also had the same problems with low quality. The studies were not using people diagnosed with apathy. And then you may have heard some of the controversy and some of the excitement. New medications come with both of disease-modifying therapies. So this graph shows you the brand new disease-modifying therapies that are supposed to come to Canada any month now. And this one's aducanumab, human immunoglobulin gamma-1 monoclonal antibody. It's directed against the aggregated soluble and insoluble forms of A-beta. What does that mean? A-beta plaques, they're the defining feature of Alzheimer's disease. It attacks the plaques and helps get them removed from the brain. So it's actually changing the disease. That's why they call them disease modifying. And this graph shows you data from eMERGE, over 1,600 patients, 50 to 85 years old. And what's different now is they define Alzheimer's disease by the presence of amyloid. So they confirm the presence of amyloid. They took people in the prodromal state, so mild cognitive impairment before they get dementia, right before they get dementia, as well as mild dementia. So those two states combine together. And you can see from the graph that I'm showing you here that aducanumab was associated with decreased neuropsychiatric symptoms overall, only in the high dose group. So high dose of the drug is in blue, placebo's in gray. This side, where you see the difference between drug and placebo, this is getting worse over time. This is declining on your score, but that means actually getting worse over time. So you can see if you look at apathy, apathy worsened in both groups. It favors the drug because it didn't get worse as much in the drug, but it's certainly not a treatment where it's improving apathy over time. So those don't work either. So what we think is that they help with emergence of apathy. This shows you the very first group of drugs, and we think that these type of drugs maybe help with emergence of neuropsychiatric symptoms. And so they're good to stabilize people on, but once they have them and they're already on the drugs, they're not going to help very much. So this shows you a pooled analysis from 2 trials. You can see the people that were on were on placebo. Here are the dark line, the people on donepezil, their light line. And this is a survival curve, but it's not showing life or death. It's showing whether you develop apathy over time or not. So you can see that they combined 2 studies, and they assessed the time to emergence of apathy. And the apathy prevalence was 49% at baseline, so half of people already had it. And the emergence was greater in the placebo group versus the donepezil group. So it may help keep people from developing these, but it doesn't help so much once you have them. Why don't the drugs that treat Alzheimer's disease help people who have apathy? If so many people have it and it's part of it, why isn't it helping? It's because we think there's some unique neurological correlates of apathy. And this is shown across disorders. It's not just in Alzheimer's disease. This review shows people with Parkinson's disease, Alzheimer's disease, and post-stroke. And no matter what kind of diagnosis you have, there are the same areas in your brain that are associated with apathy. It's the dorsal anterior cingulate cortex, shown here in green, the ventral striatum, shown here in fuchsia. And those are the core ones. And then depending on what disease you have, other neurocircuitry is implicated. So insula, dorsolateral prefrontal cortex, or orbital frontal cortex, which is here shown in burgundy. All these brain regions are interconnected, so you can't really pick one and say it's only in this region, right? So we've got interconnected brain regions. We have the core, the dorsal anterior cingulate cortex, and the ventral striatum at the core. And they all play a crucial role in normal motivated behavior. So we think that's why people have it. It's your willingness to work and your willingness to keep working and to learn what is worth working for. What happens in Alzheimer's disease? In particular, we find those exact same areas. This is another review by Theloritis et al. He found the anterior cingulate cortex, the same green region from the slide, and the orbital frontal cortex. They're associated with initiating activity and interest. So you'll see that those come up in the diagnostic criteria later on. And another review added on the prefrontal cortex. So regions of the brain that modulate motivation, interest, behavioral initiation, and reward mechanisms. Sometimes when you speak with caregivers and they're very frustrated, they say, my loved one is doing this on purpose, they just don't want to, they're being lazy. And it actually helps when I show the difference between a brain of someone who has apathy and a brain of someone who doesn't have apathy. And I say, well, but we do know that when people have apathy and they develop it, they have differences in their presentation of Alzheimer's disease and what it's doing to their brain. So they may not be trying to be lazy on purpose. So that's the state of the art so far. What do we know so far? Current treatments for Alzheimer's disease, limited impact on apathy. They target cognition, and apathy was only a second outcome, and none of these people had a diagnosis of apathy. We also know that apathy might have a distinct pattern of neurodegeneration in the brain of people with Alzheimer's disease. So what's step one to make it better? Well, it's not a thing until it's a thing. We need diagnostic criteria. So the first step that we did is to have updated diagnostic criteria. So we did expert consensus. It came out in 2021. It was ISCTM, International Society for CNS Clinical Trials and Methodology. Why go international? Because previously kind of Europe had one set of diagnostic criteria. We had another set in North America, and the FDA didn't believe in either set. So I got the FDA and the Europeans and North Americans together, and we all got together and we actually agreed on diagnostic criteria, and importantly, the FDA was part of that, and they agreed also. You're wondering why she's saying FDA. We're in Canada, we're not in the US, but Health Canada typically follows the lead of the FDA on this, so it's important to get the FDA on board so that you can get Canada on board. They're applicable in neurocognitive disorders. That's the DSM term for dementia as well as mild cognitive impairment, because we focus on observable behaviors. You can't ask someone with apathy, how did you feel the last 2 weeks? How did you feel during the last month? They typically can't tell you, and with apathy, you get lack of insight. So they may tell you, I got up this morning and I went for a 5K run, and then I walked the dog, and then I paid some bills, and then the caregiver, especially as they progress, is in the background going, you know, that didn't happen. So it's hard to have someone have the insight to tell you whether they have apathy or not. Interestingly, if their apathy gets better, sometimes they start recognizing the apathy. So they'll start telling you, you know, I haven't felt like doing stuff as much as I did before. And it's actually the opposite, that their apathy has gotten better and they're recognizing it and having insight. So we focus on observable behaviors instead of what the person themselves is thinking, especially with severe apathy. So they have to have a primary diagnosis, that's Alzheimer's or a pre-Alzheimer's state. And then there's these 3 characteristic symptoms. And the reason I showed you all the neuropathologies was to show you that these are based on what we see from the neurocircuitry that's involved in not only Alzheimer's disease, but apathy transdiagnostically. You have to have 2 out of 3, diminished initiative, diminished interest, or diminished emotional expression. So initiative, not wanting to do something spontaneously. So less spontaneous or active than your usual self, you don't initiate your usual activities. Interest, you're less enthusiastic about your usual activities. So even if the caregiver, you love to paint and you don't initiate it anymore, if they sit you in front of everything all set up, the first stage, sometimes when you initiate, they'll still show interest in it. The second stage, even if the care partner initiates, they don't show interest in it. And then there's this emotional expression part, which is probably one of the biggest reasons why it's such a predictor of caregiver burden. They don't get happy when good things happen. They don't get sad when bad things happen. They just stay the same all the time. So it's perceived as a complete lack of empathy for this poor care partner, and that's how they feel like they've lost their loved one, the selfness, the sense of self of their loved one, because they don't react to anything. Has to be a change from their usual behavior. It has to have a duration of at least 4 weeks. The usual severity, clinically significant impairment. If you're going to diagnose something and the goal is to treat it, it can't be something that's very mild. It has to cause an impact for the patient. So clinically significant impairment and the usual exclusions. It's not explained by underlying psychiatric illnesses or any underlying medical conditions. These are the dimensions of apathy. When we look cross-sectionally for people that have clinically significant symptoms, 99% will have a loss of initiative, about 89% a loss of interest, and 70% a loss of that emotion. So now we have a diagnosis. Let's see whether it's something that's druggable. We first always do the psychosocial interventions, and the study that I'm going to show you actually had the psychosocial interventions in place and kept them going throughout the study. So this is the ADMET-2 trial that came out recently, Apathy in Dementia Methylphenidate Trial 2. It was a phase 3 randomized placebo-controlled trial. We looked at people for 6 months, 200 people. We gave them either our drug, methylphenidate, or placebo, and like I said, psychosocial intervention throughout for 6 months, because that's the standard of care. You should have that in place and then see if the drug helps beyond that. So these are people who didn't respond to that. Why methylphenidate? Dopamine norepinephrine reuptake inhibitor. Dopamine, the link between dopamine with reward and motivation has been well established, and my lab in particular showed the link between dopamine and reward and motivation in people with Alzheimer's disease. So we know dopamine is involved in people with Alzheimer's disease. For the noradrenergic system, it's associated with memory, attention, energy levels, and regulation of emotions. So it's been hypothesized that together they influence the different components of goal-directed behavior. You need motivation and energization. So that's why we picked that medication. Already on the market, it's given under the trade name Ritalin to children who have ADHD. So this shows you the outcomes. We had 2 primary outcomes to look at apathy. First, the NPI apathy score, the improvement was greater in the drug group in blue compared to the placebo group. They both started with 8 about at baseline. They both decreased over time, and the change score is different. You might think that that should be bigger, but don't forget they're all getting a hardcore psychosocial intervention over time. So the drug, when you add it onto psychosocial intervention, helps people do better. This is clinical global impression of change for the drug, placebo. 44% improve when they have the drug added on, 35% in placebo, but you'll see that 21% of them get worse on placebo and only 9% on methylphenidate, which is pretty good when you look at people over a 6-month time frame who have Alzheimer's disease. The other thing we looked at is remission, so getting a score of 0. So your apathy is completely gone in people who had clinically significant apathy. For the first 100 days in the survival curve, the methylphenidate group had twice the increase in having complete remission compared to the placebo group. This extends over time, but those 2 lines become more parallel. So over 6 months, the groups become more similar. And we also, whenever you give a medication to someone with neuropsychiatric symptoms, you can make one neuropsychiatric symptom better, but you don't want to make all the other ones worse, right? So you have to look at the whole picture, and part of that in neuropsychiatric symptoms is looking at all of them. So this is a web plot, high scores, so the most behavior on the outside, a score of 0, so not having the behavior on the inside, and baselines in blue, the midpoint visits in this kind of turned green, and this one is red. So that's baseline, 3 months, 6 months. There was no difference in other neuropsychiatric symptoms except for increased aberrant motor behavior in the methylphenidate group compared to the placebo group, which is consistent about what we know with methylphenidate. It's somewhat activating, right? So we expected to see that. But you can see that over time, they all go towards the inside. So they're all, for the most part, getting better over time. Even though there's a drug placebo difference, they all improved over the 6 months. For other things we looked at, caregiver distress and cognitive measures or quality of life, there was no difference between drug and placebo. Very well tolerated. 90% completed the trial regardless of what group they were in, no deaths, and for serious adverse events, 17% in the methylphenidate group, 12% in the placebo group, but in the methylphenidate group, they were considered unrelated to the medication. It's not easy to treat apathy. This is one of the first successful trials. This shows another drug that was tried, bupropion, multi-center double-blind placebo-controlled trial, so same as ours, and a similar drug. It inhibits the same two, norepinephrine and dopamine, as you can see, that our other medication does, thank you, but it also antagonizes the cholinergic system. Remember I showed you that cholinergic drugs actually help? So it's kind of doing two things right, but maybe shooting itself in the foot the third way. So you can see that it had no significant bupropion stayed flat, placebo kind of stayed flat, but, and the proportion of adverse events was similar. There were negative effects of bupropion. So bupropion made some things worse. The emotional subscale worse, so that flattening that the caregivers really find difficult to deal with and who wouldn't, it made that worse. It made overall neuropsychiatric symptoms worse. It was worse in the drug group compared to the placebo group. Caregiver distress was worse, depression was worse, and quality of life was worse. So you can also find medications, if they're not selected right, that can actually make things worse. And then this shows that sometimes it makes it worse. We made it better. You can also have absolutely no difference. 23 people, small study, given another similarly related drug, modafinil. Both groups had a significant difference in apathy. So they had kind of the psychosocial intervention part that we had, but they didn't have the drug part on top of it. There was no significant group by time interaction. It's similar to amphetamines, dopamine and the noradrenergic system, but it also has an impact on serotonin. One of the big reasons we want to distinguish apathy from depression is it seems that antidepressant drugs, the most common ones like SSRIs, make apathy worse. So they mistake apathy for depression and they keep upping the dose of the antidepressant, but they're actually making it worse because they're increasing the serotonergic system. That's why it's important to be able to tell the difference and to have drugs that are specifically targeting apathy. So how do we move forward? ADMET-2 showed some success, but 56% of the patients actually showed no benefit. So overall group got better. So how do we pick these people? We plotted out 22 different predictors that we chose a priori, demographics, their disease state, concomitant medications, and their whole profile. And for each of the 22 predictors, we said, did they do better on drug or better on placebo? We found 6 predictors where there was a large difference in effect on the drug group and the placebo group. So methylphenidate in this study was good if you had no NPI anxiety and no NPI agitation. So these drugs can make you a bit more anxious and a bit more agitated, so you did better on drug if you had very low levels or none of that. On a cholinesterase inhibitor, that's that first group of drugs, acetylcholine, that we think helps. And if you're on a cholinesterase inhibitor and you add on this medication, you do better than if you're not on that in the background. The youngest age group, so 52 to 72, was the youngest tertile in this particular study. Normal diastolic blood pressure Why did we even look at that? It's because it's associated with the noradrenergic system, and we wanted to get some idea of how your noradrenergic system was doing without having to look at your brain. We just took your blood pressure, and it did turn out to be one of the predictors of response and more functional impairment. We know that apathy is associated with functional impairment. So you have the cognitive ability to do something, but you don't have the motivation to do something. So actually, if you had lower function, that predicted response, because then you're doing better, your function catches up with your cognitive ability. So we've got 6 different predictors. You can actually put them all together and score each patient, give them an index score, a predictor score. And we gave each patient a predictor score depending on how many of those 6 predictors they have, and then we divided them just randomly into 10 subgroups. So if you had all 6 of them, then you'd get a high score. If you had none of them, you'd get a really low score. And the median index score was negative 1.33. We did it based on the model. If you have a higher index score, just above the median, that green line, 79% now of people respond just if you're above the midpoint, and 49% if you're below. But you can see that if you're in the top 2 tertiles, you really have like an 85 or 90% chance of responding to drug, compared to if you're in the bottom tertile, so you have all of the wrong of the 6 predictors, all of the things you shouldn't have, you'll respond better to placebo compared to methylphenidate. We also wanted to look at biomarkers, right? So variability can have a biologic basis. So personalized interventions are actually how we're moving forward in this field, and part of that is being able to take blood. We looked at neuronal loss. Maybe your brain has so much neuronal loss that you can't respond to a drug medication anymore. Inflammation, maybe there's too much inflammation going on, and associated with that, oxidative stress killing off your brain scales. So we took our 6 different things and we Pareto scaled them so that we could put them all in one model again. And we did find that one, higher TNF alpha was associated with less change in MPI apathy, regardless of whether you're on drug or placebo. So if you have too much neuroinflammation, you're less likely to respond no matter what the intervention. So in summary, I showed you that apathy is common, it has a negative impact, and it doesn't improve significantly with the current pharmacotherapies that we have for Alzheimer's disease. Why? Probably because it has a distinct neurobiological profile. Moving forward, we now have diagnostic criteria that are accepted, and we know how to define apathy. And we showed for the first time, compared to some of the negative studies that I showed you, that apathy can be a drug-responsive behavior, even in people who are being carefully treated and given a psychosocial intervention and psychosocial support. Future research, validate those diagnostic criteria. We want neuroimaging and biomarkers for personalized medicine. We want to be able to monitor the treatment response and define subtypes of apathy and determine ahead of time who's going to respond. And also start identifying apathy earlier, because we know if you have apathy, even if you're cognitively normal, it's one of the biggest predictors of converting to mild cognitive impairment or converting from mild cognitive impairment into dementia. So thank you very much.
I think you did an amazing job with an overview in that short period of time. Do we have some time for a question or two? Or yeah. So I think, yeah, I mean, I know that this is an amazing area of work, and it's brand new, and there's a lot. Any questions from, maybe we'll take 1 or 2 questions. Okay, Marie.
We used a manualized psychosocial intervention that comes out of Johns Hopkins. And it gives you something that you discuss with the caregiver every time. So the structure of it is manualized, but the problem that the caregiver is having and the solution that you come up with would be individualized. So it's kind of both. It's a structure. Let's talk about this. Let's talk about initiation, for example. What do you have problems with initiation? Then you give them hints and support on what might help with initiation. So each kind of has a topic so that, it doesn't go, it also helps that it makes it consistent. especially in a clinical trial, and it gives it a certain length of time, and it kind of gives you one thing that you change at each visit. So it was 6 months of intervention. It's not hardcore like hours and hours. It would be psychosocial intervention light, but it is something that you can do that's manualized and had a big impact over 6 months, even if in these people who are, they're in teaching hospitals, so they've had a lot of care and a lot of specialist care, but they're still benefiting from kind of psychosocial intervention light given by either a social worker or a psychologist. So they had dedicated time with us. And it's also one reason that you can put people in a clinical trial and say, you know, whether you get drug or placebo, everyone's getting an intervention and everyone gets better over time, even if you've had some of the support before. I hope that answers that. Yeah, and you can find it, yeah, online.
I think there was one more question in the back. Yeah, go ahead.
That was fascinating. I don't do research in this area, but I'm blown away by what you've been showing here. I'm curious, you kind of alluded to the fact that there's perhaps a physiological link. I'm just trying to understand, is the apathy, like what would be the mechanistic link there? Is it the neuroanatomy? Is one leading to the other? Or is it an outcome of the underlying changes that occur with Alzheimer's? I don't know if I've clear.
Yeah, that's an easy question because it's both, right? So you have, so why does it happen across different diseases and Alzheimer's disease? We know with Alzheimer's disease, you have plaques and tangles, and we have kind of brack and brack, which shows you, it starts here, it moves to the front, and then it moves to the back. But within that, the one thing we know about Alzheimer's disease is that there's a ton of variation. So even with standard Alzheimer's disease, you're going to have differences in how that affects each brain and the areas that are kind of attacked, despite the fact that it kind of follows the same pathway. It's the same pathway but different in everyone. And the second point is that within Alzheimer's disease, you have all kinds of other things going on. Most of people, it's been estimated that 60% also have, vascular cognitive impairment that's contributing to that. So you have, different patterns in blood flow and all kinds of white matter and hyperintensities and other things that are going on. So even though you have a core pathology that defines Alzheimer's disease, most people have more than one cause of their Alzheimer's disease. You have different things going on in the brain. So there's the individual variation, the additional diseases going on, and the variation just within that disease, even though it follows kind of a pattern. And then, one more thing. You have the brain, but you have the environment. We talked about the importance of the psychosocial intervention in the environment. If you have someone sitting in a dark room all day and the person just leaves them there and there's no stimulation in the environment and no cognitively appropriate activities or, something that you could do, then that's going to influence it as well. So it's the person, it's the brain, the person, their premorbid condition, and the environment that are all interacting, I would think. So all of that.
All right. Go ahead. That's the last question, I guess. Yeah.
So I know you spoke about it a little bit. You already mentioned that for the psychosocial interventions, there were psychiatrists, I think, and social workers. I wonder if you leveraged recreation therapy at all in that?
So psychologists and social workers. So this was outpatient. When we do stuff inpatient, we totally use the rec therapists. At Sunnybrook Hospital for inpatients, we have a fantastic rec therapy. They have art, they have music, they have someone who comes around for personalized music and plays the music that they like in their room, as well as ukulele classes if they still got the cognitive ability. I don't have the picture with my dog in it, but I have a standard poodle. We go over and do pet therapy. We have pet therapy in the long-term care facility, and my dog is one of the volunteers, and I just hold the leash, and she does all of the work, so that's really easy. So I just stand there like this. But, and people who like pets, we talked about robotic pets, but you can actually go over with real pets and do that as well. That helps with apathy and I'll keep it short, but I have one woman who has kind of lost her ability in English, but she still speaks her first language, and she speaks her first language to my dog and tells her about her whole week, and my dog puts her head on her lap and looks up at her with her big brown eyes, and she always tells me, she speaks Polish, and I say, yeah, she does. She's good. So luckily she's multilingual too. Okay.
Thank you so much, Krista. Thank you all for your questions, and a round of applause to Krista for giving us such a nice tour of apathy and that's what we're doing about it.
Thank you, Dr. Burhan, and thank you to our speaker. Very interesting. We have the panel discussion, which is scheduled for 2:45. We'll see what we can do. Breakout sessions, we're not actually too far behind. So we're going to take a short break right now. The breakout sessions are both right across the hallway. It says Conference Center, and it's right in there. So thank you for your attention, and we'll see you at the breakout sessions.
Okay, I think we'll start. Can everybody hear me? Okay, yes, we should start. So welcome to the ADCC Showcase panel discussion. My name is Brenda Gamble. I'm a faculty member in the Faculty of Health Sciences at Ontario Tech, and I'm also a member of the steering committee. So let's get started. I will ask our panelists to introduce themselves. We'll start with Vivian.
Hi, I'm Vivian Stankopoulos. I'm a professor at Ontario Tech University and long-term care researcher advocate.
Hi, I'm Stephanie Muscat. I am the founder of a mental health organization for caregivers called Compassion in Caregiving.
Hi everyone, I'm Marie Savundra-Nigam. I'm an associate professor in the School of Health Studies at Western University.
I'm Raza Mirza. I'm the Director for National Partnerships and Knowledge Mobilization at Help Age Canada, and I also have an appointment as an assistant professor at the University of Toronto's Institute for Life Course and Aging. Nice to meet you all.
And I'm Sandy Stemp. I'm the Chief Operations Officer of an agency called RENA, which is a developmental service agency. And in the past number of years, we have specialized in support of people with dementia and developmental disabilities.
So you can see we have a terrific panel with lots of expertise. I am so sorry. The man that's not in the room.
Hello everybody, my name is Matthias Hoben. I'm so sorry I couldn't be here in person. I'm just off teaching a class on the York University Kiel campus. And given that I commute via a Brompton folding bike and TTC, I would have never made it in time. Sorry. I'm an associate professor with the York University at the School of Health Policy and Management. And I'm also holding an endowed research chair in dementia care. My research really focuses on improving the quality of life and health and well-being of people with dementia as well as their caregivers. And actually just last year I attended that panel as well, that very same panel, and met Lauren Bates from the Ontario Caregiver Coalition. We started to make connections, and I do partnered research, so I closely partner with people like Lauren and others to inform my research in an advisory role. And Lauren said, yes, let's do that. But she flipped that around and made that actually researcher-involved advocacy. So I have gotten quite engaged in the activities of the Ontario Caregiver Coalition. So just full disclosure, much of what you're going to hear from me today is based off what I've learned in that role as well. Thank you.
Thank you very much. So as I was saying, we have an excellent panel here with lots of different expertise. So it's going to be a great conversation. I'll just give you the format of the panel discussion. Each panelist has 5 minutes to speak in succession. Then after that's over, I will ask each panelist a question, and then we'll open up to the audience. So we'll start with Vivian.
Okay, hi. So I came into this whole world of dementia accidentally, mainly through the route of long-term care. So I was someone that did a lot of caregiving research for my doctoral education as a young person who cared for older adults. We called them young carers, young caregivers. But then as the grandparents I cared for, we all tend to come into this through some sort of personal bias, right? And I don't, hide mine. I was very close with my grandparents, cared for them. So I had a grandmother moved into long-term care, and she passed just right before the lockdown. And I knew how often I was there, and I knew how involved family caregivers were in long-term care, when the majority of residents in long-term care have dementia, right? So these populations overlap. And when effectively the pandemic struck, my whole focus kind of shifted rather accidentally to fighting the lockdown procedures and policies. And because I knew right off the bat, like most family caregivers in here know, that when you suddenly take away your access to your loved ones and all that care that goes with it, it's just a disaster waiting to happen. And that's exactly what happened. So I started being very public and vocal and just yelling at the government pretty much every day for 3 years. I'm sure they love me. And just fighting. My whole goal in that first 6 months of the pandemic was just fighting to get loved ones back into these facilities because they were completely locked out. And you know, the whole premise was that, well, we're trying to protect them, but we all know it didn't, because the virus just ripped through those facilities with them locked out. And you know, our whole goal as family caregivers were trying to get them reunited and get them back in there, obviously safely, because we knew how important their role was. So, you know, my whole need for being here and trying to share the information we learned through not only what happened and the experiences I had with families that reached out to me during the pandemic, but then also research that I did with essential family caregivers of loved ones in long-term care. I mean, we really saw how devastating that separation was and how it can never happen again. I mean, the trauma that occurred, not only for the residents, we all know, we all heard of the confinement syndrome, we all knew that the research was clear, we predicted this would happen, but these seniors were dying not from any acute respiratory distress, but from being left alone. And we had that research very early on out of France. We knew it would happen. It made sense why it would happen, because the residents and their loved ones weren't there to help feed them, help ambulate them, help care for them. All the things that significant, you know, population of unpaid caregivers that's often invisible in long-term care and other congregate care living facilities provide. So the research we did with essential family caregivers really hit home just how traumatic it was for the families locked out. Not being able to provide that care was probably one of the most stressful things that these people ever experienced. They, you know, one of our papers that we wrote and published, you know, the title was "It's the worst thing that's ever happened to me," and it was a direct quote from one of the family members, and that's pretty much how people felt. The trauma lives with them still. They had to live with knowing that in their absence, their loved ones declined to a point that was irreversible, especially at that age. We heard stories of these people, these residents just stopped eating. There wasn't enough staff to feed them. When they finally got reunited with them and were excited, it was met with shock and horror, because they were sometimes 20, 30 pounds less skin and bones. We heard analogies of, you know, prisoners of war, how they looked when they finally saw them. It was atrocious. Some family members completely forgot their loved ones. The, you know, cognitive stimulation was just absent in their absence, right? So it just irreversible harm. And then the other thing that really stood out is that, you know, this whole terminology, essential family caregivers, was actually created because the lockdowns, which was so offensive, overnight just decided the family was suddenly non-essential. So if you've ever heard that term, essential family caregiver, we created this term, this group of you know, doctors, academics, researchers, family members, as a direct kind of backlash to governments just willingly saying, you're non-essential. All of a sudden, family's non-essential. So we, you know, are really trying to impart that not only can this never happen again, because we saw how devastating it was for the residents, but particularly also for the hundreds of thousands of Ontarians who are loved ones of these residents and had to deal with forced helplessness, being looked down upon by administrators and by the government as non-essential, not being listened to, kind of being othered almost overnight. And you'd hear this us versus them mentality. So some of the things, you know, that we tried to deal with are, and I think, you know, we'll talk about this more in the Q&A, and I'm trying to see if I'm almost at the 5-minute mark, is having laws. And one thing we worked on early on, me, some family caregivers worked with an NDP MPP, Lisa Gretzky, to table a bill, Bill 203, the More Than a Visitor Act, trying to mandate and continue that access and that support for families across all congregate care living facilities. Because this happened not only in long-term care, retirement home, hospitals, and that's my cue. So we'll talk more in the Q&A part, but thank you. So.
That's what they asked for.
Yeah, I said, give me the love tap and I'll know. Thank you. Thank you.
Okay, next speaker is Stephanie.
Yeah, so I was actually working inpatient during that time in a transitional care unit. And some of what I'm going to be talking about today correlates to my work with caregivers and their care partners that I was working with in the hospital. But I'm going to be talking about caregiver apathy specifically today. And there are a number of reasons why I've seen caregivers become apathetic throughout their caregiving process. Now, I tried to do a literature search on this, and I did not find anything specifically on caregivers of those with dementia who are experiencing apathy. So I'm going to be talking from a subjective standpoint, again, from my 10 years of inpatient hospital experience as a social worker. I'm a social worker by background, but also based off of my private practice in my psychotherapy practice with caregivers. So the first reason I would say caregivers experience apathy is probably one of the more straightforward ones that we see, which is some sort of a depression, a mood disorder. It doesn't even have to be formalized in terms of diagnosis, but a lot of the caregivers I work with experience profound sadness, isolation, hopelessness, helplessness, feelings of being abandoned by our system, which I'll talk about a little bit later. And in that, they start to experience apathy, whether that is a learned approach to remove themselves from the experience that they're going through because they can't handle it anymore as a defense mechanism, or whether it's something that has happened over time because of whatever they're experiencing, whether it is a depression, sadness. We can see that apathy is directly correlated with depression a lot of the time, not all of the time. And in studies with caregivers, it has been shown that depression is one of the main mental health concerns that caregivers present with above all. So we can see how the two might be tied. I also see a lot of caregivers who are experiencing burnout, and apathy can also result from burnout, but not always. I work with a lot of caregivers who are burnt out, and we cannot always say they are apathetic because most of them are absolutely not. They just don't know what else to do, and they very much care. I also come from the lens of a caregiver myself. My mom has frontotemporal dementia, and I was 19 when she was first diagnosed. I'm an only child. And I will say also that we can't forget the more hidden behavioral variants of dementia. We talk a lot about Alzheimer's, and there are so many difficulties in caring for someone with Alzheimer's. But I have to say that when it comes to caring for someone with a behavior, many caregivers take it on themselves to think that they are the reason or they are the result of the behavior. And many times they're not. And particularly with my own mother, in terms of what I experienced that could result in apathy, I couldn't even walk in front of her without her swearing at me. When you're caring for someone 24 hours a day and trying to do your best and trying to be everything for them on top of managing the healthcare system, on top of relational concerns outside of this, and you're getting that type of behavior, you think there's something wrong with you. So you are going to become completely apathetic to the situation, to remove yourself from the circumstance. So that's the first reason. The second reason I see apathy happening a lot in caregivers is relational. Whether you have siblings who are not coming forward to help you in caring for your parents, maybe there's a difference of opinion, maybe there's a power of attorney that encompasses all siblings and you are not agreeing, and that's making you very upset, so you remove yourself, you're not interested in doing what you did with your siblings before, you frankly can't care anymore because that's how you're going to cope. Also with friends, people that you thought maybe supported you in the past, who are not coming forward, or potentially friends who thought that you were one way and now they're saying to you, oh, you're different, I'm not going to engage with you. That personally happened with me. You become apathetic to those friendships, you become apathetic to wanting to engage in social circumstances with these people. The third reason, and again, the thing I'm going to talk about the most today, is navigation of our healthcare system. 60% of caregivers who come to talk to me are not coming to talk to me because of their caregiving duties and what they feel they're doing day in and day out. It's because of their concerns in navigating the healthcare system, feeling that they are left out of the interprofessional care team when in fact they should be a primary partner in the care team, feeling that they have nobody to talk to, feeling that they've been completely isolated and feeling hopeless. And those are really primarily what I see. We have to remember, and that's my cue, so I'm going to talk later. I'll talk more about that.
Okay. Wow. So far we've learned from both of you of all the problems that are there in terms of apathy, in terms of the system really not supporting family care providers, and some of like the negative aspects of receiving care. And so my work is focused on what are some of the solutions. So could I get a show of hands of who here is a family care partner? Okay, a few. And who here works in home care or community care? Okay, quite a few, good. And what about long-term care? Okay, excellent. And so what I'm going to speak about are some of the key issues in home care and in long-term care and in community care. And that is when you're working with a person living with dementia. And that is responsive behaviors. So those are their behaviors that signify some type of unmet need. And the critical incidents that come as a result of that, which include things like elder abuse or resident on staff violence or the opposite of that. And what I'll be speaking about is a solution to address these key problems. And so we developed a training program called Be Epic, and now virtual reality version of that program called Be Epic VR. And it teaches frontline staff on how to be person-centered in their care. I had the privilege of speaking to persons living with dementia, and I asked every one of them in different roundtables, what is one thing that you want researchers to focus on? And every single person living with dementia said, quality of care. Interestingly, nobody said cure, because they already have dementia, and for them, quality of care was really key. And so for us, like the training program that is on communication, we really view communication as care. And most frontline care providers, specifically personal support workers, they do the most work, but they are the ones who get the newest training the last, right? They're prioritized the least. And in our program of research, we really wanted to, from an equity perspective, put them at the forefront, put them first in terms of providing that training program. So in the next part, I will talk a little bit about what's involved in Be Epic VR.
You still got a tap?
Yes.
Oh, you still got a tap.
She
Okay.
followed her time. That's why she didn't need the tap.
Okay. Well, thank you so much for the invitation to be here. And I'm a gerontologist, and sometimes I have to explain to people what that is. Well, I study gerontology, and I've been in the field for 20 years. And if I make it scarier, I've been in the field for 2 decades. And we sometimes talk about decades in the context of generations. And so I'll ask you, do you know what generation you belong to? Yeah? Do you know why your generation was named what it is? Do you? No. No? You do? Okay. Well, there's no naming body in the world that's, the Department of Naming Generations. But it's not arbitrary either. But I'll go back a little bit further and I'll tell you a little bit about generations and the notion of generations and the importance for caregiving. So back in about 1928, an article is written and it's called The Problem of Generations. And it's actually a French study. And in looking at the problem of generations, what this article was highlighting is how interdependent one generation is on the generation ahead of them and also the one that's behind them, and how there's a sense of responsibility within these generations. Mm-hmm. So generations are also considered birth cohorts, so people who are born within the same birth cohort. And if you look at caregiving, for example, you have familial and non-familial generations. And in that context, it's people within your own family who are younger than you, one generation younger than you, are a generation as well. But then there's also social generations for people who are not necessarily related to you. And what we've already heard from Vivian and Stephanie is that when you're a young caregiver, you are caring for someone who's a generation older than you. And how do you fall into that responsibility? Well, by proximity, by relationship, etc. And so the study of generations is really looking at, well, What are the differences and similarities between generations? And part of the Canadian social contract is that, well, younger people will look after older people, and older people will look after younger people. And oftentimes when I'm giving talks like this one, I bring this Maclean's magazine from about 5 years ago. And if you're a Maclean subscriber, maybe you've kept this one, but it's a double issue. That's why I kept it. And on one side, no, I keep all of them, but that one particularly I kept. And on the front of it, it says, "It's all your fault, boomers." And on the other side, it says, "It's all your fault, millennials."
Oh, that's awesome.
And the reason I'm holding this notebook is because I wanted to share one very specific statistic. It's also written on my hand. 63% of millennials say that their best friend is actually their parent, who's is their boomer parent. So all of that to say that this sort of warfare that was highlighted in this article, this generational divide, does not necessarily exist in what we see. And there's a lot of interdependence based on historical context, et cetera, between generations. And if you look at caregiving, especially for chronic long-term conditions, if you look at dementia, a third of people who are providing care are children to their parents. And as the population grows older, that number is going to increase. And so that generational dependence is really, really important. Now, in my own previous life as a caregiver, and I also will always identify as a caregiver, there were times when there was tension. So generational relationships are sometimes talked about in the context of tension, but there was a lot of solidarity, there was a lot of exchange in my caregiving relationship with my dad. And I will tell you that there was a really pivotal moment, and I hope if you remember anything that I say today, that this will be something that you remember. That on one of my tough days of caregiving, I was really struggling, I was a grad student. I remember this one person said to me, you know, it's not you being their care partner, it's not you being part of their circle of care, you're a care gifter. You are gifting the care to someone. It is something that they can never maybe even repay you for, but it also works the other way around. That person is gifting you with the opportunity to provide care for them, because it's very, very difficult to be the recipient of care as well. So don't forget that. And I think that really helped to reframe my thinking about what my role was and how I was providing the service and care to my dad, but also formal caregivers, whether you're in the community or you're in long-term care, you are really gifting someone your time and your expertise and your care, and you're taking care of someone's treasured loved one, like I was with my own dad. And the thing that I'll leave you with here is that I think that the generational divide really does make headlines. I think it shows that, you know, there are scarce resources like healthcare and home care and housing and education, et cetera, that really there are generational differences in our approaches to them. But I think that there's greater solidarity and opportunity here than there are differences, and that I think we really have to think about what society we want to live in, one that's based on mutual care and support across generations. And so that's what I'll talk about in the next in the next part of what I'm saying. Yeah, thanks.
Can you see me? No. Can you see me? You're next. Yeah.
Yep.
Can I? Dr. Holborn, you're next.
All right, sorry I missed that. Like Vivian, I actually come initially from a strong focus of my research on long-term care, but I've more and more shifted my focus to the community, noticing that there is this strong movement that they call aging in place, and aggressive approaches and aggressive attempts to keep people in the community, which conveniently shifts care to the family and friend caregivers largely. And there, conveniently, it largely becomes invisible because it's largely unpaid care. So this is why it looks so much cheaper than what's going on in nursing homes. And also, another thing that Vivian mentioned is that during the pandemic, the lockdowns all of a sudden made caregivers non-essential in these nursing homes and assisted living facilities. In the community, conveniently, again, it was flipped around. Their home care services stopped their service or cut them down quite drastically. And all of a sudden, the caregivers had to take over, right? So it seems like the system has a tendency to flip that around in whatever way currently suits them best. And caregivers are not always at the forefront of politicians and health system decision makers' minds. So the things that we've talked about a lot in the Ontario Caregiver Coalition are related to how to better support caregivers on a very systematic level. And I think there is two major things that we should advocate for. The very first thing is, well, first of all, get systems to think about that issue systematically to start with. There is no caregiver strategy, roadmap, anything like that at all. I know that the Canadian Centre for Caregiving Excellence, in collaboration with all the provincial caregiver organizations, including in Ontario, are working on such a strategy, or like advocating for a caregiver strategy. And I think that's a very important thing to put in place, like the dementia strategy that Canada has put in place. And second, such a strategy must focus on the person in need of care and the caregiver at the same time. They're intricately linked. And I think we have a tendency to think these two things separately. But we're currently working on 5 different policy briefs, and I am leading a policy brief on caregiver respite. And when you talk about caregiver respite, you can't define caregiver respite without thinking both ends. Like, yes, there is services like an adult day program, but they automatically serve both people, right? They give the person in need of care meaningful interactions and physical activity and arts-based things that are going on, but it's also giving respite to the caregiver. If you support the caregiver, you automatically support the person in need of care. And if you support the person in need of care, one worry less for the caregiver. So we need to think these both things together and not separately. And very often they're thought separately. And that just shows in the design of our policies. If you look into, we did a survey with 612 caregivers, and just the most highlighted things, the ones that most commonly were mentioned, were the impact of caregiving on people's mental health. So with all the benefits and gratifications that come with caregiving, caregivers to a large extent struggle with mental health. And some of the discussants have mentioned things like apathy and burnout and things like that. Navigating systems is just something that's so incredibly tiring and near impossible at times. Juggling caregiving and other responsibilities. Often caregivers have multiple caregiving responsibilities. They may care for their parents and for their children and for their neighbor, right? And that's all intricately linked. Giving caregivers a break, that's the respite end of things. And then the financial impact of caregiving. There is very marginal financial supports in place, like tax credits and stuff like that. And across the board, and that's to wrap up my my argument here, is all these services suffer from fragmentation. They have very complicated application processes, so caregivers sometimes lack the time, energy, and to even support them. Many are associated with some out-of-pocket expenses that are later refunded or not even, which is a big barrier. Awareness is a big support. There is no proactive approaching the caregivers to even make them aware of certain supports. Caregivers are very good in just pressing on and carrying through and not asking for support themselves, or not even in all the stress noticing that there is support needed. All these different things, supports like flexibility, and very importantly, the quality of the supports are very important too, right? And not just for the caregiver, but something like an adult day program or other services that focus on the person in need of care. If they don't work well, the caregiver is most likely not going to expose the person to that again, and yet again, one other support is taken away. So that's my plea for now, and I'm pretty sure we can follow up on many of these things. Thank you.
Well, I'm going to be speaking a little bit on a different topic. This is about people with developmental, or I'll refer to them as intellectual disabilities. And certainly it's what I call a big success that people with intellectual disabilities are living chronologically much longer than they used to. However, this does mean that they have various age-related challenges and diseases, including dementia. And we're just learning more about how adults with intellectual disabilities are at risk for dementia. And certainly there's some research studies out there that show that they're at quite an elevated risk, but there's a lot more research that is needed in this area. However, we do know that people with Down syndrome are at very high risk. 80% of people with Down syndrome will be affected by dementia by the age of 65. They experience it at an earlier age, and they often have a precipitous decline. And dementia poses a very unique challenge for families and other caregivers for adults with intellectual disabilities affected by dementia. And one of the sort of our impetus that we belong to, or we created, which was the National Task Group, Canadian Consortium on Intellectual Disabilities and Dementia Practice. And they partnered with RENA, the agency that I work for, and advocated for the inclusion of people with intellectual disabilities into Canada's National Dementia Strategy. And that was a long and hard road, but we were successful. So advocacy matters, that we were included in Canada's strategy, Chapter 6, and it acknowledges this population as one facing barriers to equitable care and at higher risk. And as such, grants were then put out through the National Dementia Strategy, and we have just completed a Public Health Agency of Canada grant to update existing 2013 community guidelines and adapt them to a Canadian context. And so we have created this guide. This is my shameless plug. I actually have some if you wish them, and I've got a couple in French. And I also do have some of the tools and resources. So see me afterwards if you would like one. Believe me, this is blood, sweat, and tears. And also, all of the materials are available on our website. The project was really, informed by incredible groups of people, many, many family members, people with intellectual disabilities, and staff caregivers. In fact, we found a large number of people with intellectual disabilities that were actually caregivers of their parents with dementia. We had an advisory group of families, organization representatives, and experts. The audience for this guide is really broad. It's for clinicians, caregivers, family and staff, organizations, and adults with intellectual disabilities. It's really also meant for those in the health and seniors field who typically support those with dementia, but don't necessarily have expertise in intellectual disabilities. So we really hope that this appeals to a broad audience. The piece with this project was also to develop a lot of resources. It has an extensive reference list, and what we like are those clickable links, especially for people looking for resources. And one of the big resources that we are trying to increase more awareness about is the early detection screening tool for dementia, because oftentimes people with intellectual disabilities, first of all, clinicians don't know how to diagnose dementia, and as such, it's often diagnosed very late. And we've also created a number of other things. So we've got the early detection screening tool for dementia. We've got some great overviews. We've got booklets for families, staff, and individuals with intellectual disabilities. So really simplified versions on each stage of dementia and what do you do and who might help. We have videos that we have shown, and in fact, many videos of people who just work in the generic dementia field say we love them. They're 2 minutes. One's for people with intellectual disabilities, staff, and also and organizations. We created an FAQ specifically for adults with intellectual disabilities based on what we heard from them. And although there are differences and unique challenges for caregivers with intellectual disabilities affected by dementia, we really believe that some of these tools will be very helpful to them.
Okay, thank you for everybody sticking to their 5 minutes. I really appreciate that.
Almost.
I've had other experiences with other panels. Anyway, so now we're going to have a question period. And as I said, I will be asking each panelist a question, and then we'll turn to you, the audience, for your questions. So Vivian, what policy changes or changes to the law do you think we need to implement to better support caregivers?
Well, for my pandemic experiences, I certainly want a law like Bill 203 to actually happen, where you can never separate caregivers from their loved ones ever again. Provide training, provide supports, do whatever, and these family members would have done whatever you asked them to. They would have jumped through any hoop, but just never separate them again. It's just not okay. And then I think the most glaring thing is training, dementia-related training, is so necessary, especially considering the fact we're gonna have, what, 1 million Canadians with dementia in the next 15 years? And, sometimes I get calls from media to do interviews, and one I got not that long ago, a few months ago. Remember if you heard this. I'm always like, what? So a reporter called me and said, listen, I want you to comment on a story at Michael Garron Hospital. Anyone hear this? And I'm like, okay, what is it? And they're like, well, a woman who was sent from a long-term care facility to a hospital for help somehow was put in a headlock and effectively abused by a security guard when she was just having a responsive behavior because she was blind and pretty much deaf and was confused. And obviously, then she ended up being abused by this security guard. And it made the news, and the hospital was effectively trying to hide it, and it got leaked by the family because they weren't happy with how the hospital was responding to this. And I'm just like, I'm sorry, he did what? He put her in a headlock? In a headlock. How are we at this point where not every single frontline care worker at a minimum is trained on responsive behaviors and dementia and knowing who your patients are? The anger I get from even recounting that story is still fresh. It's like a 9 out of 10. It was about 15 out of 10 when I first heard it. And my media interviews were not very subtle that day. But not just that, right? I had another interview given 2021. There's one personal support association, if you've heard of them, OPSWA. I have my issues with them. So I got another call saying, so there's these very dehumanizing, ageist, derogatory TikTok videos being pushed by this formal organization, effectively mocking persons with dementia that are the main care recipients of this organization. And I'm like, I'm sorry, what? This association has received $1 million plus from the Ford government. So I mean, I'm worried about what our future looks like for our aging population, and given the fact that, apparently dementia-related training is non-existent in a lot of areas, and there doesn't even seem to be some sort of ethics or integrity with respect to what organizations are receiving significant amounts of money from the government to represent these workers who are to care for this population. So I'm concerned in that area, and I think that's one of the biggest things we need to deal with is really training anyone in a frontline position anywhere, but certainly at a minimum, anyone working in a healthcare position to understand responsive behaviors and dementia-related needs and have that specialized training. And unfortunately, what I've seen and what's certainly happening under this Ford government is that they are deregulating our healthcare workforce and actually making things far more dangerous for the growing population of people with significant care needs that won't have proper care provided to them. I wish I was more optimistic there. I'm the Debbie Downer of the group, so I'm sorry about that, but that's, yeah.
Thank you, Vivian.
Yeah.
Thank you. Okay, Stephanie, how might apathy towards healthcare providers or the system impact not only the caregiver, but the person receiving care, and what we can do to shift the caregivers' experience?
So just tagging along what I said earlier, and sorry I didn't keep to my time earlier, but I'm going to give a story of someone that I worked with. I'm going to make sure it's non-identifying so that we're not going to relate it to the person. But I think this very much shows just how caregivers are feeling and being treated in the system. So this person specifically actually had not engaged with her father in 10 years. They had a very traumatic history together, and unfortunately she was the only family member that was around. There was nobody else. Her father was admitted to hospital with a dementia and a fall, and she was called, and she said, you know what, I have no other choice. I am going to support him as best I can, but I have my boundaries given the history of what we have. Unfortunately, from the very beginning, and I see this a lot with the people that I work with, she was not called, she was not spoken to, she was not engaged by the healthcare team. And I am not saying this is everybody. I also worked on the healthcare team side of things, and I'm not going to start to talk about what the concerns are there because it's very top down. But what I will say is that she wasn't given an opportunity to voice where she was coming from. She wasn't given an opportunity to say what was happening in the home. And she wasn't given an opportunity to say what was not possible. She was living at home with her 2 children, a full-time job, and suddenly, 2 weeks after her father was admitted, she got a call from the hospital saying, tomorrow your father is being discharged, he can't go home, he is coming to live with you, and we are going to put supports in the home with you. And she lost it. Like, can you imagine? And she said to the person, this is not happening. I cannot do this. And they started to see her as a barrier to discharge. They started to see her as the angry caregiver, as the person who was not working with the team when she was never included in the team to begin with. And so unfortunately, after many failed attempts at speaking to the team, she called me, which shouldn't have to happen, and I became a mediator in that situation, given my experience, and also I was working as her clinician, to speak to the team to say, listen, you don't understand her side of things, right? We understand that you want discharge. We understand that this person is ALC. They're not acutely requiring care. But you can't throw this on this caregiver and then assume she is the angry person. And we had a conversation, soon realized they knew nothing about the history. There was no trauma-informed care, which we don't see happening at all. And we created a plan within 2 days that could have happened 2 weeks prior, could have, removed the father from a hospital bed. And all of this happened and caused so much aggravation and stress for the caregiver. I see this all the time, and caregivers are going in and out of the system having these repeated experiences. So when they're coming into the system, they're already feeling extremely upset, extremely removed, and extremely angry. We have to start at the top. Again, education. Education has to start in university. It has to start with, how do we support the caregiver? What do caregivers need? There is an excellent training by Caregiver-Centered Care in Alberta. It's research and evidence-based, and they have 4 modules. It's free. You can take it wherever you are. I am a huge advocate of it. I'm not sponsored by them, but they're wonderful. We have trainings in our hospitals for many different things for interprofessional team members. We have to include caregiver training as part of mandatory training in hospital. We need to work with caregivers from the beginning. Less than 1/3 of caregivers are asked how they are doing. They want to be heard, and they want to say how they are doing, because they are the ones providing care 24/7, going 20 years without a break. So we have to work with them. They can't be seen as the enemy. They have to be seen as part of the care team. We have to foster communication and a healthy team environment with them, and not rupture what is already there, because the care recipient relies on the caregiver.
Thank you, Stephanie. Marie? Can you walk us through the key features of BEPIC VR? How does it address critical gaps in dementia care training?
Sure. I'm so glad that, Vivian, you talked about dementia-related training, right, or dementia-specific training. That's one thing that the frontline really doesn't get. So when they get their training, it's mostly on, especially the personal support workers, but also other healthcare providers. They get training on maybe the activities of daily living, but but not specific to dementia care. And that's really why we developed BEPIC VR, and that the foundation is communication. Because once the way that you communicate, whether it's like the verbal communication or the nonverbal, that's really critical in how you present yourself. Like when you walk into a room with a person living with dementia, that person living with dementia will know if you're happy or sad or mad or glad, right? They do have that sense of, what's the vibe that you're giving when you're in that room? And so what we do in this training is we teach what is person-centered care and what is person-centered communication. It seems so lofty, right? Those are the lofty goals that we have. And so what we've done is we've taken the foundations from for the work of Tom Kitwood, where he had 24 areas of positive person work that came from the late 90s. And I looked at those 24 characteristics, and there's 4 that are very that's focused on person-centered communication. The first is to recognize somebody, to negotiate, to facilitate, and to validate. Again, that sounds really wonderful, but again, how do you do those things? How do you recognize? How do you negotiate? How do you facilitate? How do you validate somebody? So to figure this out, we've looked at many of the research studies that I've done, but also colleagues in nursing and speech language pathology and psycholinguistic. We know the strategies that sort of overlap, the language-based and nonverbal strategies that overlap with these person-centered goals. So in BEPIC VR, we teach what does person-centered communication look like? What does it sound like? What does it feel like to be person-centered, but also what does it feel like to receive that person-centered care and communication? And then you learn how to do this in our BEPIC VR version. You learn how to do it first in 2D through these highly interactive training where you actually learn, you look at videos of what's person-centered, what's not person-centered, and you really learn about stigma. You learn about some communication, some language that's used, likely unintentional, perhaps intentional, that we've heard from our data on stigma. So when you ask a person, if you had a questionnaire and you asked a person, rate yourself on how stigmatizing you are, everybody says that they're not. But if you ask them, hey, tell me what's your day like in taking care of a person living with dementia? So we did this with home care PSWs and long-term care PSWs, and that's when the stigmatizing communication comes out. I don't think it's intentional. I do think they come from a good place, but just don't know. They don't get that training on what not to say. Sometimes they'll say things like, dementia patients, or they'll say things like a poopy diaper, instead of talking about briefs. But I think it's because they don't get that training. So in BEPIC VR, we really teach with kindness so that you learn where are some opportunities that where you did really well, where are opportunities that you glowed, and where are some opportunities for you to grow. So in BEPIC VR, you first learn all of that, what is person-centered communication, you learn about stigmatizing communication, you learn that in 2D, and you have these scenarios where you really practice applying some of the newly learned skills in 2D. Then you put on the headset, and then you practice it with an avatar living with dementia. And we use conversational AI using I have lots of real communication samples between PSWs and persons living with dementia in long-term care and in home care. So we know the good, bad, and the ugly, right, of that communication. And so we're able we also have communication data between persons living with different kinds of dementia and family caregivers. So we have a sense of what their communication is realistically, so we can create these avatars that are realistic but not stereotypic. And they really, once you put the headset on and practice with the avatar that's realistic, you really kind of hone down your person-centered communication skills.
Thank you, Marie. Raza, your question. It's a long one. Okay, ready?
Get ready.
Sure. Yeah.
What is the role of using intergenerational connection / practice to support caregiving? For example, your work on using intergenerational classroom and Canada Home Share program as a platform to build bridges across generations to create a more engaged, age-friendly, and dementia-friendly community.
Okay, sure.
Okay.
So I'll highlight that those are 2 programs that I run. One of them is the Canada Home Share program. It's an intergenerational home sharing program where older adults with extra space in their homes can rent out their room to students or to other older adults. And the other one is an intergenerational classroom where university students are actually going in and learning in a retirement community in a long-term care home, and I'll tell you a little bit more about that as well. But the most important point I'll tell you about both of those programs is that there is a mismatch between the person and the environment. That is a simple thing around both of those things here. So with the Canada Home Share program, what the community needs we're highlighting and signaling to us is that there's all of these older adults who are lonely, they're isolated, they need a little bit more money, and actually they just need some help shoveling the snow or someone to walk their dog. And the people who were calling and asking me about that program were not the older adults themselves, but it was actually their adult children who are saying, I want to keep my parent in their home, I want them to stay in the community. Actually, I just need someone to walk the dog because my mom doesn't want to let go of her dog because in the retirement community or the next place that she would go to, she won't be able to take the dog with her. So that program, in that specific example I'm giving you, allowed that person to stay in their home for 4 additional years. They had a cognitive impairment, but they were able to stay in that home for 4 additional years. And I can tell you that when we are advertising programs like that one, we have a huge interest. There are lineups for people coming in and saying, hey, I'd love to have that opportunity. The minute you say to them, you'll be living with an older person, they say, no thanks. But the people who actually do participate in the program really reap the benefits of that. The intergenerational classroom is a class that I took 2 decades ago, where I was told that this is the career of the future. And to your point about education and schooling, and I will tell you that this is one of the only undergraduate classes on aging at the University of Toronto. And it remains so. So the pipeline of caregivers and others who are interested in aging remains the bottleneck for most of us. Now, what I noticed over the last, 10 years or so is that the average age of the undergrad students and of my graduate students started to increase. And actually having people of different ages in the classroom really improved ideological diversity. It gave us a different lens to look at things and said, hey, actually, you know what? The textbook says this about isolation. The textbook says this about caregiving, but these are my real experiences. And so last year, what we did is we actually partnered with Christie Gardens Apartment and Community and took our entire class and brought it into the long-term care home and retirement home. So 25 of my undergraduate students were in a class with 25 learners from Christie Gardens who were residents in that retirement home. And the residents in that retirement home were actually enrolled in the class. And they came prepared. They came prepared, they highlighted their notes. This year, we're running the class again. We actually have 2 of the older learners from Christie Gardens taking the exam and doing all the assignments with us. So we can see the evolution of this. But what I'll tell you is that it has really improved the sense of social responsibility. It's changed the empathy levels of students and we did some research and evaluation around this as well. But most importantly, it addressed ageism. And if we get to the next part of our round of questioning, I'll talk about ageism. But ageism is the root of many of these issues that we've seen. And it wasn't just one way again. It wasn't the younger people holding ageist views towards the older people. The older people also held very ageist views. And this is sometimes the barrier. It's not immutable, but it is a barrier between that communication and collaboration and synergy across generations that we've been able to address using these 2 platforms. And the final thing I'll say about that is that actually we have to be very intentional. We have to be intentional in our approaches because we have in many ways unconsciously and consciously segregated age by society and by generations. And so now we have to go back and sort of undo that and bring people of different generations together. So that's the 2 programs there.
Thank you very much. Okay, Dr. Holborn, you're on the screen there, and I've got you in the right order. So, are there any lessons learned from other countries, international perspectives, in the implementation of caregiver policies?
Well, where to start? Yes, there are definitely many lessons that we can learn from other countries. The first that always comes to mind is like the Scandinavian model, where the health system is funded very differently, organized very differently, and where the government plays a much bigger role in organizing, delivering, and overseeing things than here, where taxes are higher and more of the tax money flows into the system. I've just recently seen a report where different European healthcare systems were compared with respect to what's available for supports for caregivers and how easily or difficult they were to access And surprisingly, like you may hear that from my accent, I am actually from Germany. Germany, along with Norway, they were actually at the highest level of accessibility and comprehensiveness of these services. Well, I think what they do different is, first of all, they have less means testing than we have here. Like if you want tax credits or any other supports that are publicly funded, very often it's not just what's your actual support need in the sense of how burned out are you and what type of support do you need, but also how much money have you left to take care of that on your own, and what's your minimum income threshold, and if you're above that, you're not getting that service. These kinds of barriers are way lower in these countries, so that the financial supports to start with are more comprehensive. They're far, like if you ask caregivers there, they also have the struggle to make ends meet, but accessibility is higher and the amount available is higher too. And secondly, social workers play a much more comprehensive and bigger role in helping caregivers and people navigate the systems. So social workers or case managers. That is something that we're sorely missing here. Like navigation of systems is one of the biggest struggles, and that's also related to the fragmentation of the healthcare system. Like there is generally these two barriers that are predominant in just about everything: lack of organization and lack of funding. They lead to conditions that are just mind-blowing. And if you're a burned out caregiver, somehow finding the supports you need is just very challenging. I've just completed with my team, just for curiosity reasons, a review of all 52 Ontario healthcare teams' websites. And I asked a couple of my students, some of them didn't have to pretend, they are caregivers, but I told them, you're a caregiver, go on that website and try to find information on what supports are available for the person you care for and for yourself. And the exercise was very, very eye-opening. We had a little bit of a scale of how easy or difficult was it to find information, how confused were you, then add comments on what the website looked like and what kind of supports you found and stuff like that. And it's very different. It really depends on in which region you're located and who's responsible for you, right? So that kind of a more aligned healthcare system with one-stop shop, one information where you can find all the information in place, one place basically where you find all the information, and a case manager helping you to navigate the system. These are definitely things we can learn from other countries, and really not just Western countries. I mean, not sure how many of you are familiar with the Cuban healthcare system. Like, not that I have personal experience in that system, but I've talked to students. We have a bit of an exchange program where students spend 2 months in Cuba over the summer, and they have these primary healthcare teams, small care teams with a doctor and a nurse and some other staff, and they're consistent. They're accompanying families in their little neighborhood across the whole spectrum of care, across the journey. So it's one care team who knows this family and who actually goes there, rings the bell, and asks them how they're doing and what supports they need. So this proactive outgoing approach, where proactively people are asked what needs they have and how they can be helped, that is definitely something that we can learn from other countries, and that's sorely missing here, I think.
Thank you very much. Sandy, what is different about caregivers for people with intellectual and developmental disabilities and dementia? What are their unique challenges?
Well, certainly one of the biggest ones is the length of caregiving. So caregivers of people with intellectual disabilities has had the entire lifetime of their family member of caregiving. So that's huge. You can imagine the stress and how worn out people are. The other piece is that the advocacies and their struggles and challenges, they've had to advocate throughout that person's lifespan, right? They've had to advocate in the school. They've had to advocate in healthcare systems and in social service systems. And they would have had like a lifetime of stigmatization, discrimination, and exclusion. And they would have experienced a lot of differences in philosophy over time. So a lot of families or caregivers are saying, that the approach to support people with intellectual disabilities has changed dramatically, and they would have witnessed that. The other piece is that typically for individuals with dementia, caregivers are often spouses or children. People with intellectual disabilities, that's not the case. It's either their older parents, and you can imagine, I've known people that are supporting their family member with an intellectual disability and they're in their 80s and they're in their 90s, or the siblings. And the siblings have a very unique caregiving experience, very different than their parents. And it could be very complex. They could have felt really overburdened with care at a much younger age. And some were actually excluded because many family members or older parents have said, I didn't want them to have that caregiving. But of course, when the parents can no longer provide support, then often the siblings must step in. And this can be really challenging and it can bring very complicated emotions. The intensity and the form of caregiving is also different. So if you think of a family member with supporting their adult child with a developmental disability, routines, schedules, how their days go is really important. It's important for the person, but it's also important for the caregiving. When the individual has dementia, now all of that has changed. The schedule is turned upside down, the length of caregiving and what they do. And then it brings new challenges where perhaps the person didn't have behavioral issues, now they do. The caregivers get exhausted and frustrated because many, they can't get care. So disability services say, oh, well, now the person has dementia. Their needs have totally changed. They can no longer come to a day program and to other supports. And senior and dementia services may say, oh, I'm sorry, we can't support them. Yes, I know they may have dementia, but we don't know how to support people with intellectual disabilities. And senior and dementia services also may say they're ineligible, because if 80% of people with Down syndrome have Alzheimer's by the age of 65, they need the help at 55. But most senior and dementia services will set age limits and won't change them when we say that that's discriminating against somebody's genetics. Also, they often say you need a confirmed diagnosis of dementia. Well, if nobody can diagnose dementia in people with intellectual disability, then people are excluded. So these are some of the differences that are not well recognized by this unique population and are a significant challenge to caregivers.
Thank you very much. Unfortunately, we don't have time for questions from the audience. I apologize for that. But I'd like to give a big round of applause to our panelists and the great job they've done. Thank you so much. And Tim tells me we have parting gifts for you.
Oh, stop. I thought she said party gifts. I was like,
Can we offer to hang out for a few
Yeah,
minutes?
we can hang out if anyone has questions. Like,
sure.
If people have questions, I think most of us can stay. Yeah, sure.
Everybody hear that? There's an opportunity to ask questions.
Yeah.
if you got to run, run.
I've got books.
Thank you.
Oh, yeah, you have books as well. The books.
Listen.
Yeah, I'd love one of those. Actually.
Oh, would you?
Yeah,
There you go.
I want one.
Here's what.
Thank you. Nice to meet you as well.
Oh,
I don't think so. No.
There was a course there 20 years ago.
Oh, really? Yeah. No, I wasn't.
Oh, thank you so much. Thank you so much. Thanks.
And I guess our fellow on the line is so good.
everyone just works.
Oh my God, I don't even know how he
Just to repeat, panelists have offered to stay after we close if you have questions you'd like to ask them. So Jennifer and Phil are coming up to give closing remarks. Is this correct? Yes? Yes.
Who's first? Okay, I know we're standing between you and the end of, I'm sure that's been a productive but long day for you. Mostly here, I'm Phil Klassen, I'm Vice President Medical Affairs and Research here at Ontario Shores, and mostly just to make sure that we say thank you to the people that need to be thanked in an enterprise of this magnitude. Thank you to all of you for coming, and thank you to the Planning Committee to ensure the success of the event. We want to acknowledge Kevin Frankish and Kristen Welsh, from Ontario Shores, as well as Alison Carruthers from Ontario Tech, and thanks also to Kevin for emceeing. Acknowledging Caitlin Gambier, I'm sorry I don't know the correct pronunciation, from the VP office at Ontario Tech, and of course Amanda Nixon, the two EAs that have been critical in supporting the planning committee and generating and developing the program that you've seen. Thanks also to Food Services and Jennifer McDonald for providing the refreshments, and last but perhaps most significantly, the leadership and vision of Drs. Amar Burhan and Winnie Sun for being co-chairs of the Advancement for Dementia Care Centre. Their commitment to advancing research and care for people living with dementia and their families have resulted in significant contributions to the care and treatment through the application of technologies like the ones that you saw today. And I've seen this as well. They started 5 years ago with the launch of the Clinical Demonstration Unit here at Ontario Shores, a new model in this respect, and they deserve credit for their many accomplishments over these past few years. We all look forward to seeing what the future holds for the advancement of dementia care for the staff, patients, and families here. So thank you very much. And then I turn it over to you.
Hello, everyone. So I am truly between you and your home. So you may notice that Dr. Les Jacobs was to give the closing remarks. He unfortunately had a delay, and so you have me, and I've had a couple of seconds to prepare for today's closing remarks. So bear with me. No pressure at all. But I'd just like to say a big thank you to all of our speakers here today. It was truly incredible to get the various perspectives from some truly experts in the field and those who have had lived experiences. When I was thinking about this, I was thinking about the title of this, Putting the Pieces Together, Overcoming Apathy to Build an Engaged Dementia Friendly Community. And when I was looking at the definition of apathy, it was a lack of interest, enthusiasm, and concern. And I looked at this in two ways. One, we talked a little bit about the clinical way. So looking at it from the treatment and how we treat that and some of the new drugs that are needed to treat apathy and how that is important, and recognizing apathy and how it's underrepresented within the clinical care. Also the need for the clinicians and the caregivers to be working together with all of the health teams involved. The need for technology to enhance treatment and the importance of doing that and making sure that we really provide quality care. And we heard a lot of that in the keynote speaker and a lot of the work that's going on in the ADCC. But the other sense is around the community sense and all of us and all the role that we play. The caregivers are central to that, the individuals with dementia that, and thinking about the apathy that sometimes exists within the community and how do we break that apathy. And I think the speakers really talked a lot about how do we break that apathy in the system? How do we make sure the system is more navigatable? That's not really a word, but is easier to navigate. For all those that are involved in it, because it is difficult to navigate. How do we make sure that caregivers are given the support that they need? How do we make sure that in hopefully we don't have another COVID-19, but if we have a situation like that, that we don't remove caregivers from the central need, which is to see their loved one in long-term care. How do we fix that? How do we fix situations that we talked about, where the home setting is not appropriate to having a parent with dementia care in the household. And so I think there's so many things there to say that there's lots that needs to be changed, but we're all a part of that change. And we need to kick the apathy in its butt, and we need to really have a call to action. And I really think there was a lot of passion today. We heard a lot about the international setting. We heard about technology. We heard about those with disabilities. I think there's so much there that we can take from today. We can put our own action into motion and work together as a community to really put the pieces together to drive forward dementia care and to really make a unified, engaged community. So I thank everybody that was here today. I think it was absolutely fantastic. I hope you learned as much as I did today, and I really thank all of the panelists for your excellent perspectives and everybody else in attendance today. So thank you very much, and have a wonderful evening.